Professor Manu Malbrain. So everybody knows him. He is the president of International Fluid Academy and also a very avid researcher. And he has lots of publication related to fluid and also abdominal compartment syndrome. And we would be privileged to have the talk on how to manage the fragile kidney. So yeah.
Society International Fluid Academy. I will discuss how to manage the fragile kidney in sepsis and what is important. As said, I'm internist intensivist from Belgium, and I consult for different companies as medical advisor. So let's kick off with an introduction. Sepsis is a time-critical emergency, and it's balancing the microcirculation with the microcirculation. AKI is also a time-critical emergency. We know medical conditions where time is of the essence, like myocardial infarction or ischemic stroke, where you have a couple of hours door to needle time, or polytrauma, where you need to have a full body CT, and sepsis, when there is 1 hour door to antibiotic or IV fluid time. So it's like a golden hour to preserve perfusion to the organs. So how do we do this? If we look at mammals, heart rate can differ importantly, but if we look at the mean arterial pressure, it's quite the same in small and large animals. Why is that? Because of the waterfall effect. The heart has to pump the blood. So we have the mean arterial pressure, the CVP, the mean systemic filling pressure. At the level of the organs, there is the perfusion pressure. At the arterial line, the mean arterial pressure drops to 50. So perfusion is key. Perfusion is determined by the preload, the venous return, afterload, resistance, and contractility of the heart. So at the level of the kidneys, you have the perfusion pressure is the difference between the back pressure and the forward pressure. So let's move on, and this is the topic, will be the topics of my talk. Some giveaways. We have 2 million nephrons, and each nephron counts. AKI is a syndrome. It's not a disease. It can occur within many conditions and disease states, like sepsis can be accompanied by AKI. Yet most of our surgeons, at least it is, don't pay proper attention to perioperative AKI or AKI that could develop in the ICU. Like in this patient with abdominal sepsis after perforated viscus, comes into the ICU, drop in blood pressure, drop in CVP, drop in urine output, maybe PPVSI or the passive lag raise is positive. So at the end of the day, the patient may have received a couple of bags of saline. Why is that? It's kind of a reflex. Whenever something goes wrong in the ICU with our patients, we believe that some fluids should be good. On day 2, we see the abdomen is distended, creatinine has increased, and by day 4, urine output drops. There is a positive cumulative fluid balance, further increase of creatinine, and CVVH is started hemofiltration. On day 7, there is sudden cardiac arrest, and there is a decompressive laparotomy at the bedside. There is acute mesenteric ischemia because of secondary abdominal compartment syndrome, because of fluid accumulation syndrome. So abdominal hypertension is a killer, but AKI is also a killer. And the question is, did you measure the intra-abdominal pressure, and did you do everything to prevent AKI? We're humans. Humans make mistakes. To is human, but let's forget about the mistake and remember the lesson and start your kidney care bundle, especially in patients with sepsis. So we learned that fluids can be life-saving, and this goes back to the blue stage of spasmodic colorines, kind of deeply ingrained in our brain and culture that fluids are life-saving. However, just because you're fluid responsive doesn't mean you need to be given fluids, or that you're fluid tolerant, or that you have tissue hypoperfusion. So let's now move on to some definitions. AKI is a rapid decrease in glomerular filtration rate causing an accumulation of waste products. Decrease in filtration rate, increase in waste products, and this can be accompanied with or without a reduction in the amount of urine output. We have different definitions going from Rifle, Akin, KDIGO. They're all a little bit the same, but it's a combination of urine output and creatinine values. Perioperative AKI, when KDIGO criteria are met within 7 days after surgery, And when acute kidney disease is when it starts in the first 7 days and persists beyond. Chronic kidney disease if it develops beyond 90 days. And the same holds true for AKI in the ICU in patients with sepsis. So let's move on to the epidemiology of AKI. So the prevalence, the exactest prevalence is not known, but as many as 70% of critical patients will experience some degree of AKI according to KDIGO criteria. And approximately 5% of patients in the ICU will receive renal replacement therapy, and the hospital mortality in this group is quite high. Whenever there is acute kidney disease present, this is associated with hospital mortality, and after adjusting for differences in comorbidity, it is associated with a 5.5 times greater chance of death compared to matched controls without acute kidney disease. Also, if the patients do need renal replacement therapy, then mortality is also increased, especially if the patients are older as compared to controls who don't need renal replacement therapy and are younger of age. So, acute kidney disease is frequent in critically ill patients, especially those with sepsis, is associated with increased hospital mortality. And if the patients do need renal replacement therapy, again, mortality is increased. So the incidence of major adverse kidney events at 90 days could be in high-risk groups and ones with severe sepsis septic shock up to 25-50%. Also, if these patients, as in the case I presented with abdominal sepsis, should undergo surgery, we have a lot of preoperative risk factors, intraoperative risk factors, and postoperative risk factors related to diminished blood flow to the kidneys, the type of surgery, as well as increased oxygen demand. So now let's move on to the pathophysiology. Perioperative AKI in the ICU is related to sepsis, the presence of sepsis, hypovolemia, nephrotoxic drugs, concomitant other organ failure like cardiac failure, or hepatic failure or lung failure, or the patients with a cardiorenal dilemma, hepatorenal syndrome, or those with advanced decompensated heart failure. There could be issues of obstruction at the ureters. The surgery could involve also extracorporeal circuit, ECMO use, like in COVID patients with a lot of inflammation. Patients in ICU could have rhabdomyolysis, vascular injuries, abdominal hypertension and compartment syndrome, diabetes mellitus, all these risk factors. So sepsis, concomitant organ failure, major cardiac or non-cardiac surgery, and the presence of shock, low blood pressure, perfusion pressure. When it comes to nephrotoxic agents in the ICU, patients are given antibiotics, immunosuppressive agents, NSAIDs, concomitant therapy with angiotensin-converting enzyme blockers, or maybe radiographs with contrast media. And usually there are more than 2 risk factors present. So the pathophysiology, as illustrated by this infographic, is very complicated. But it all comes down to the following. As I told you in the beginning, it's the imbalance between the macro circulation and the microcirculation and how perfusion affects the kidneys. And this may result in damage associated molecular patterns. So with the shock, we have the drop in blood pressure, drop in abdominal perfusion pressure, and usually, especially in abdominal sepsis, but in sepsis and fluid accumulation in general, there may be an increase in intra-abdominal pressure. So abdominal perfusion, renal perfusion will drop. This may lead to a vicious cycle where we need to administer more fluids, maybe also vasopressors, and this may lead to fluid accumulation syndrome. If fluids are accumulating in the presence of sepsis and capillary leak, we have this global increased permeability syndrome, interstitial edema, oxygen can't get to the tissue. So it's a combination of pro-inflammation, hypercoagulation, and hyperpermeability, and the imbalance between the macro and the microcirculation that will affect the kidneys and the nephron. If you look at the kidney with respect to forward pressure and failure, so a drop in cardiac output, and the backward pressure, so an increase in CVP or intra-abdominal pressure, it seems that backward failure is more important than forward failure or a drop in cardiac index. As Mullins found out in patients with decompensated heart failure, he saw that the increase in CVP was related to worsening of the renal function on the left, whereas on the right, there was not much difference with respect to cardiac index. Is this also the case in sepsis? Yes, it is. The higher the CVP, the more risk of new or persistent AKI. And with respect to that, it seems that intra-abdominal pressure is like the canary in the coal mine for AKI, as was shown in this study. This is in patients undergoing cardiac surgery, but you can see at the moment they are extubated. There is an increase in intra-abdominal pressure and there is a decrease in urine output. So going back to the cartoon of the waterfall effect, when abdominal pressure is increased, you see that perfusion pressure and abdominal perfusion pressure and renal perfusion pressure is further decreased. So we have to understand these interactions between different organs like the cardio-abdominal renal interactions and looking at renal perfusion pressure. Because it's not only the mean arterial pressure, but also the CVP, the intra-abdominal pressure may play a role, especially when it comes to glomerular filtration pressure. Here we can see in the formula that it's filtration gradient MAP minus twice the intra-abdominal pressure. And you have this kind of auto-regulation where a MAP of 65 is probably fine, but there is no much hard evidence. And we probably need a higher MAP in case of abdominal hypertension and other comorbidities like pre-existing arterial hypertension or in the presence of sepsis, as well as patients with diabetes. So if we look at the inflammatory mechanism, the primary hit or insult, whether it's viral, fungal, bacterial, whether the patient has sepsis, burns, trauma, pancreatitis, there will this pathogen-associated molecular patterns, but also the damage-associated molecular patterns. There is this pattern recognition receptors, and this will incite what we know as the cytokine storm that will result to distant injury and inflammation. So now we have our patient in the ICU with sepsis, abdominal sepsis, who is at risk for AKI because of the comorbidities, the diabetes, pre-existing situation. So we have to assess the risk of our individual patients to develop AKI. So what about finding a biomarker, which is defined as a characteristic that is objectively measured and evaluated as an indicator of normal biological processes, pathogenic processes, or pharmacologic responses to the therapeutic intervention? It's quite a difficult NIH definition. The FDA says is any measurable diagnostic indicator that is used to assess the risk or presence of disease, AKI. So if we now go from normal kidney, no kidney disease, to the kidney at risk, subclinical to AKI, and then eventually failure, we need to diagnose and stage, and typically this occurs over several days. So it's a continuum for risk of complications, non-recovery, mortality, and healthcare costs. But because we can only use the serum creatinine, we only have a late detection, and a lot of complications and costs have already developed. So this is the CADIGO markers, creatinine and urine output. So we need novel biomarkers to identify the golden hours where we can still save the kidney. And there is an unmet needs for these new biomarkers. So let's go back to CADIGO with serum creatinine. It's not a marker for injury or damage, it's a marker for GFR. And the diagnosis is delayed because you only measure it once a day. So basically you have about 48 hours delay in diagnosis. The damage has already occurred, so it's difficult for prevention, but we should not throw away our old friend. The ideal biomarker needs to separate between injury and function, could be early or late. Identify maybe patients that will need renal replacement therapy, predict outcome and mortality, and maybe identify subphenotypes of AKI. So we can also have this kind of urinary biomarkers with insulin-like growth factor binding protein 7 and tissue inhibitor of metalloproteinases 2, TIM2, where you can do a check and this will predict the risk of AKI. And you can see that before and after using this kind of urinary biomarkers in the patients of cardiac surgery that will develop stage 2, 3 AKI was significantly reduced by 89%. So after the risk assessment, what about prevention of AKI? And I think key is to monitor. Measuring is knowing. So any hemodynamic monitoring, as I showed you, the forward failure, cardiac output, but also the backward pressure. We know the 5 vital signs, which is the heart rate, blood pressure, saturation, respiration, temperature. I would like to add continuous urine output and continuous intra-abdominal pressure to that. Second, we have to avoid perioperative, but also in general in ICU and sepsis patients, hypotension. Because studies have shown that the intraoperative hypotension is related to postoperative adverse outcomes. And this was also shown by Ashish Khanna, where he was looking also at different thresholds from 55 to 75 of mean arterial pressure in relation to AKI mortality and so forth. Next, after the monitoring, avoiding the hypotension, so avoiding forward failure, we must also avoid excessive salt administration. Why is that? If you look at the SALT ED and SMART studies, critically ill and versus ED patients, you can see that balanced solutions carried a better prognosis when it comes to major advanced kidney events at day 30. This was significantly, so we should aim for chloride poor balanced solutions, and it's about time to stop abnormal saline. Why? Because it has tremendous impact on end organ function. Next, avoiding the salt will also lead to avoiding fluid accumulation syndrome. As we know that fluid accumulation at the outside mirrors fluid accumulation at the inside in each and every organ system. This will lead to venous hypertension, venous congestion, and also for the kidneys, this will result in a vicious cycle of salt and water retention and AKI. This global increased permeability syndrome needs to be avoided because these fluids are rich in cytokines and will incite ongoing inflammation and hyperpermeability. Everything you need to know about de-ristation and avoiding increased back pressures at the venous side, it can be found in this open access paper that also summarizes the ROSE framework from resuscitation, optimization, stabilization to evacuation. Fifth point is avoiding venous congestion. And this could be assessed, for instance, with a very popular VEXA score, looking at Doppler signals of the portal vein, the hepatic vein, as well as the renal vein, and calculate a grading score. And the study has been shown that the VEX score was better to predict worsening renal function as compared to CVP, but needs to be pointed out that the initial studies were done in cardiac surgery patients. If you remember the case of abdominal sepsis that developed fluid accumulation syndrome and AKI, and then abdominal compartment syndrome and died. If we went back to the case at some point, intra-abdominal pressure was 21, so we should avoid intra-abdominal hypertension because it also has deleterious impact and effects on all organ function. Is there any other things that we can do besides this short list? What about dopamine, theophylline, dobutamine, bicarbonate, and so forth? There is, as of today, no evidence to support these other treatments. So what about definite treatment? Need to remember that we have to individualize and personalize our treatment and pick that unique patient that may benefit from an acute kidney care bundle. So we have to understand what is the definition, how to classify, how to avoid risk factors and concomitant factors, what we can do to support forward failure, improve cardiac output, decrease backward pressures. There are many studies showing these kidney bundles. And depending on the stage of AKI, there are different things that we can do from, of course, discontinuing the nephrotoxic agents, as I told you, about the volume, about the salt, avoiding also hyperglycemia, have diagnosis, and then at the end, maybe predict the patient by using biomarkers, either in the serum or urinary, who will need renal replacement therapy. If you implement these kidney care bundles, a systematic review showed that you can reduce by 22% moderate to severe AKI in ICU patients. We previously showed that if you use a continuous urine output monitoring tool, that you can detect about 80% more AKI in mixed ICU patients. So, early identification of AKI in the ICU with continuous urine output has been shown in other studies that the diagnosis can be made about 1 day or more earlier. And this study, it was about 41 hours earlier with continuous urine output and continuous intra-abdominal pressure measurement. We recently published in Postoperative Medicine the study on optimization of kidney function in cardiac surgery patients with abdominal hypertension, taking into account the AKI stage and implementing a stepwise approach, looking at abdominal pressure, abdominal perfusion pressure, urine output with the monitoring and drug and other actions to have this kind of kidney care bundle. So, humans do make mistakes, and this is not the end of the story, but it's the end of my lecture. So, to wrap things up, the pathogenesis of AKI in the perioperative and ICU sepsis patients is multifactorial. Sepsis AKI is the DAMS-PAMS associated toxic nephropathy. Post-surgery, as in the patient here, is usually the DAMS. Could be complicated by other toxins or drugs. Hypotension is important, the pressure time burden. Avoid too much fluids and too much salt. RV dysfunction can also worsen AKI. Intra-abdominal hypertension can worsen AKI, and also here there is this pressure time burden. Venous congestion can also worsen AKI. So biomarkers, preoperative, we have traditional risk assessment, use the CARDIGO EKD definitions. During surgery and in the ICU, go for monitoring. The forward pressures, stroke volume, target sufficient mean arterial pressure should be high. Patients with concomitant hypertension, and we know that early renal replacement therapy or early diuretics is not beneficial. There is a lack of specific treatment, and we should assess kidney health serial manner. So it's about time to implement kidney care bundles. Having said that, I thank you for your attention, and I invite you to join the International Fluid Academy.
How you actually take furosemide for AKI management in sepsis? When is the best practice in starting and ending?
Is a very good point. So I think it goes along with fluid accumulation syndrome or patients at risk for fluid accumulation. So when you want to restrict fluid intake, this you can do by withholding fluids, so not starting fluids when they are not needed, for instance, but also by withdrawing fluids, so coming down with the speed or the volume of the fluids, which we also call de-escalation. When we talk about administering diuretics, we're talking about de-resuscitation, which is the active fluid removal. In this case, I would suggest to start with a furosemide stress test. So you give 1 milligram per kg for furosemide naive patients and 1.5 milligram per kg for those who are already on furosemide. You give this as a bolus intravenously, you wait for 2 hours, and if urine output is beyond 200 cc, patient passed the test and is probably not at risk for AKI, but may be ready for the resuscitation. So that would be my first recommendation. Next, I would look in this setting to the albumin levels, and in case of low albumin levels, below 30 grams per liter, maybe it could be wise to substitute the albumin levels to facilitate fluid movement from the extracellular to the intravascular space and then remove them with the diuretics. There have been some studies showing a synergistic effect of hypertonic albumin with the furosemide. But the problem is that you will see in ICU patients with sepsis AKI that this will work for 1 day or 2 days, and then urine output drops, and you will not achieve a substantial negative fluid balance on a daily basis. Maybe sodium levels will increase or other electrolyte disturbances. So if it's really fluid accumulation syndrome, which means any percentage of increase in fluids accumulated with new onset organ failure due to the accumulated fluids. And then I'm talking about high lung water, low oxygenation, abdominal hypertension. Then maybe it's wise, if the patient is resistant to diuretics, to move on to renal replacement therapy. So you have metabolic control of the electrolytes and you have control of the negative daily fluid balance. The other thing that I might say is that sometimes a combination of diuretics, so not only loop diuretics, but maybe combine them with acetazolamide, spironolactone, or indapamide or thiazide, like sodium clearing diuretics, could be an option.
Yeah. So it is a double sequential blockade therapy. Yeah. So yeah, very nicely told. So one last question from my side, like how do you reconcile the need of early goal-directed therapy when we are getting more strong evidence for the fluid restriction, particularly sepsis-associated AKI, SAKI. So
Yeah, is a very good point. So we learned from studies that mean arterial pressure is important, but maybe it doesn't tell the whole story. So I think, and there are some cases and studies, albeit small series, but prospectively, that looking at mean perfusion pressure, which is the MAP minus the CVP, or abdominal perfusion pressure, MAP minus intra-abdominal pressure, or the renal perfusion pressure, which is MAP minus abdominal pressure minus CVP minus mean alveolar pressure if the patient is on positive pressure ventilation, that these perfusion indices are much better in prediction to AKI. And there the threshold for renal perfusion pressure should be above 40 millimeters of mercury. So rather than chasing a MAP target of 65, I would rather go for abdominal perfusion, renal perfusion, targets in combination with early vasopressors, because then you have a synergistic effect. You recruit fluids from the unstressed volume to the stressed, and as a sepsis is about, it's a vasoplegia and it's an increase in unstressed volume that you can recruit back with vasopressors. Maybe also a combination of vasopressors, so not waiting till you are at 1 gamma of noradrenaline before introducing vasopressin or terlipressin, especially in patients with liver failure and abdominal sepsis. So I think limit fluids, combine with early presses, get your perfusion pressures, take into account previous history. If the patient is known with hypertension, then maybe the thresholds need to be higher. And we'll see in the future if there is a place for hypertonic albumin earlier. Now we only use it at a later stage for de-resuscitation.
Yeah.
And thing is, so if you're giving fluids and you don't achieve your pressure targets and you start with vasopressors, maybe the fluid accumulation is just a biomarker and a sign that something is still going wrong with your patient. Maybe source control was not good. Maybe the surgeon did not a good job. Maybe the antibiotics are getting resistant. So accumulating fluids in a sick patient is always a bad sign and could be indicator of poor source control or other things that you may need to sort first.